when I originally organized this, I was worried that I was going to be the only person that showed up. So I'm really glad you guys could make it. My name is Michelle. And I originally started thinking about doing something like this for my own information, for some of my friends who I knew were dealing with some post-baby issues and they're running. So I hope you guys find it informative and helpful. This is Lori Sivitz. She's going to be given the presentation today. She's a physical therapist with United Physical Therapy. She also works at Geneva Woods Birthing Center. So she has been doing physical therapy for 25 years. Something like that, yeah. Okay. That's pretty close. And she has done primarily outpatient therapy, physical therapy, has background with the birthing center, and then she is she's done a whole bunch of sports. She's ultimate frisbee, hockey, biking, ran a half marathon. So just a wealth of information. I've been seeing her myself for core strength, and she has been so helpful and so informative. So I think she's going to be able to provide you with a lot of good information today. If you find it helpful, even going to see her I read a lot of information about postpartum core work, recurring the transverse abdominis, and I was reading information and trying to do things at home myself, but really ultimately going to see someone's the only way that I could have someone teach me how to recruit those muscles and get my core strength back. So while this is I think that you'll find this helpful, it may just be something you have to go and see somebody that if you still have questions after today. All right, that's good.
Thanks, Michelle. Gosh, thanks for coming out today. A couple things to start off. We printed out some of these for you. You don't have to take notes. There's not going to be a test. This is my first time speaking to a really large group, and it's not quite the way I had set it up. So my pointer doesn't work. So I'm going to use the pointer on the computer here, and you'll just have to bear with me. It seems like we can't get away from the intrusion of computers and technology in our life, no matter how hard we try. So I don't currently work with Geneva Woods Birth Center. I did work as a birth assistant with them for about 10 years. I got to see a lot of out-of-hospital births. I got to start putting my hands on pregnant women postpartum, and that really got me excited to work with pregnant women and in my physical therapy practice, which is sort of now swung all the way over to not just pregnancy, postpartum, but pelvic floor health in women and now in men as well. And the more I learn, the more surprised I am at how large the population is of people who have problems with this, and they don't have a place to get information, or they don't have a way, an avenue to get help. And a lot of the doctors don't even know it's something to do. So today, thanks Michelle for having me. This is definitely a passion of mine. And today we're going to focus on diastasis, recti, abdominis, and urinary incontinence. So to be fair, I have been through a lot of continuing education courses that are multiple days in length where we discuss these issues, and there are a lot of books that are written about the topics individually. So we're going to have a general overview and try to cover some things that might help you with any questions you might have, and maybe give you some resources on where to go and how to get information and get better. So we should talk about what these things are. And I have a picture here of 3 bellies. I've got the first one. I guess I don't need the pointer at this point. First one I have pregnancy, then I've got pregnancy, and then I have postpartum. I'm sure all our bellies look like that. Diastasis recti is a separation of the right and the left halves of the abdominal muscles, the rectus abdominis, your six-pack core. And how that separates is there's a connective tissue called the linea alba, and it starts way up here at the rib cage and runs all the way down to the pelvis. And it's a connective tissue that all the abdominal muscles connect to. And it separates by thinning and stretching. And the causes that make that happen are excessive weight gain, and that can be during pregnancy. It can be just for weight gain. We see it in men with large beer bellies who look like they're going to have a baby. But it can also happen in really strong athletes who do a lot of years of intense abdominal work. They work really hard on their obliques, and it can pull and actually separate their linea alba even if they haven't had children. So that's not always a cause, right? And then this would be postpartum, where we see it's a little bit improved, but not all the way resolved. So, urinary incontinence that we're going to talk about. The ones we're going to talk about today, there are three relevant to our discussion. First being stress urinary incontinence. This is unwanted leakage due to increased abdominal pressure, coughing, sneezing, laughing, jumping, running, all the fun stuff. Urge incontinence is unwanted leakage associated with a really strong urge. So if you can picture this, you're out and about, driving around all day, you're fine, you pull into your driveway, all of a sudden you have to pee so bad, you don't even think you're going to make it to the restroom, and so you have to leave everything in the car and run to the bathroom. And some women don't make it, and that would be related to urge incontinence. And then the third type would be mixed, which is a combination of the two, which I think seems probably obvious. So one study that was done demonstrated that 66% of women with a diastasis recti, a separation in the abdominals, will have some form of pelvic floor dysfunction. And that includes urinary incontinence, fecal incontinence, which is leakage of the bowels, and pelvic organ prolapse, the dropping down of our organs a little bit lower than they are intended to be. Okay, so diastasis recti can be an important factor in having a pelvic floor dysfunction. And that's why that makes it important. A large postpartum study of women showed that 45% of women postpartum will be incontinent or have some form of incontinence at 7 years postpartum. 30% of those women were not incontinent immediately postpartum. So clearly something happens to women during pregnancy and labor and delivery that affects the pressure management in our canister, either immediately after having a baby or over time. So these numbers are large, and women get told to do Kegels, and it doesn't always help. So we'll talk about what it is. Okay, so we'll start with diastasis recti, and here's a picture that might look familiar to you if anyone reads Michelle's. These are our abdominal muscles. There's actually 4 layers of abdominal muscles. First we talked about is the rectus abdominis, the 6-pack muscle. Then I have it helps with bending over, getting up from the floor, or getting up out of bed. Then we have the obliques. We have an internal oblique layer, an external oblique layer. They help with rotation forces and twisting. Underneath all of that, we have this dubius transversus abdominal muscle. It goes all the way from the rib cage down to the pelvis, wraps all the way around the front, attaches into some thick connective tissue in the back. When it contracts, there is a narrowing of the waist and a flattening of the stomach. Okay? And it works in conjunction with our core muscles, our deep stabilizing system. And this is a really nice handout that my colleague has made for her website. So we have here the diaphragm, the deep back muscles, the multifidi, transversus abdominis, and down the floor of our canister here is the pelvic floor. We're going to go into detailed anatomy of that a little bit further on. This is our core system. It works in an anticipatory fashion to help stabilize our bodies. Essentially what that means, if I go to lift my arm, milliseconds before I do that, I get an increased contraction of this deep system to stabilize my spine and give myself a platform to work off of. Okay? They should work together in a very efficient, coordinated manner. I don't want to have overactivation of any of these muscles or any underactivation of these muscles, or I can lose the optimal system for breath, support, and control as is listed on here. And if we take a look to this side view here, we can see that she's talking about breathing here, and when I breathe in, the diaphragm should drop down, the belly should come out a little bit, the pelvic floor should also drop down. So as we talk about the health of the pelvic floor, we want to remember that there should be a full range of motion, not just a tight, contracted pelvic floor, but a pelvic floor that will move through its full range. And during breath, it should drop down, and then on exhale, it comes up, the diaphragm goes back up, the belly comes back in. So different factors can disrupt this system and make it less efficient. And that could be trauma, could be pregnancy, labor, delivery, surgery, or just repetitive stress activities, doing the same thing, sitting at a desk all day, doing tons of crunches or standing in a way that's less than optimal. So if we take a look at what happens in pregnancy, pregnancy changes our posture, and I think we're all used to seeing that or being that person, right? With the belly shifts way forward over our feet and our trunk shifting back. It's very common. It can affect neck posture as well. Once I change my alignment and I don't have my head over my shoulders, over my pelvis, over my ankle, then that deep system can't recruit as well. It's kind of put in a position that makes it harder to turn on. So this can affect what happens, let alone the weight of the growing baby putting more pressure on your pelvic floor and on your lower abdominal and stretching those tissues out. These changes often persist postpartum. I think if we were to truly look at some of this, we might see that a lot of women have those postural changes before they get pregnant, and pregnancy kind of highlights them. So sometimes we're even working off of a deficit before we ever get pregnant. I don't have a study to back that up, but I think it's worth looking into. So if I don't get my alignment back, I don't necessarily get that good recruitment of my deep stabilizing system. Essentially, the pelvic floor muscle or the transversus abdominal muscle will get turned off and then not necessarily turn back on postpartum. So if those muscles don't come on, I don't just fall to the floor. I've got other muscles that'll sort of be ready to step up and do the job. They're not as efficient at it, and they can change how I manage my pressure in my system, but the obliques are really quick to turn on and try to do the work. Back muscles back here, sometimes hip flexors will get really tight and try to do the job, or even just stabilizing by breathing and holding our breath or pushing out. So we can get different compensatory movement patterns that develop. And if we do that, then we're at risk for musculoskeletal problems, back pain, hip pain, pelvic girdle pain, urinary incontinence. It can even affect shoulder and neck as well. So now we know, how do we check and see if we have a diastasis recti? This is pretty typical. I'm sure a lot of you have probably seen different things online. When we look, we have people lie down, knees bent, fingers right in the midline. Have them do a little bit of a crunch up, lift their head and shoulders. We're feeling for the gap between the heads of the rectus muscle, okay? Anything that's 2.7 centimeters or larger is considered clinically relevant. That's about 2 fingers width. Someone in my office just last week, about 3 weeks postpartum, she was 5+ fingers, okay? I've seen men, not at my clinic now, but when I've done some fit for duties, that have like 2 hands, they're separated. We don't just check for distance, but what we also look for is what's the integrity of that tissue below the opening. So when I press in, I should hit that linea alba pretty superficially, like a trampoline. There's tension there. And when it thins and stretches, it can get soft and boggy, and you can often sink your fingers way down in where you almost feel like you're going to hit their spine. And that tension, that integrity of that tissue is probably more important than the distance separation, because that tells me if I can transfer that nice corseting action of my core across from my right and left half of the body to be nice and stable. So we look for distance and depth. So here we have postpartum belly. I'm going to tell my husband, he thought it was a pillow. I'm sorry, but here we have the belly, right? And this, you can see that the connective tissue is loose and wrinkly. Some degree of diastasis recti is normal postpartum. You just stretch these tissues out over the course of your pregnancy. Postpartum, we need time for that to recover. It takes time, that elasticity to heal and get back together. And while it's doing that, we want to avoid any activities that might reinforce or aggravate that separation, okay? So now we get to the really tricky part. What exercises are good for diastasis recti? Well, I'm here to tell you, you should avoid any activity that causes your belly to dome out or protrude while you do it. Remember, if we think about the transversus abdominis and what it does is it's a gentle narrowing of the waist and pulling in of the belly, okay? That could be getting up out of bed. That's why they tell you to roll your side and get up. It could be getting up out of a chair. It could be crunches. It could be downward dog. Everyone does stuff a little bit differently. So we have to look at you individually and say what's happening in your body when you do these activities, show you what it looks like, and show you what to avoid. There is no magic exercise that corrects diastasis recti, unfortunately, or nobody would have it, right? What you need to do is to work on alignment, correcting this posture or this posture, getting that deep system to recruit, and avoid breath holding and gripping. There was two studies that were done in 2005 and 2007 where they took women and they measured intra-abdominal pressure, what's happening in here and how much pressure is happening with different activities including cleaning, jogging, sit-ups, crunches, and what they found was there was a wide range per individual. Some women could do those activities with really low pressures, which means that it's probably pretty safe for them to do, and other women could not control the pressures and the pressures were really high, and those activities would be unsafe. So our takeaway from that is it's probably more the strategy that you use to do the activity than the activity itself. Okay. So now we know we need to fire the transversus. How do we know if we're firing the transversus, right? You can't, just like Michelle said, you can go online, you can think you're doing all the right things. How do we know it's firing? So when we check people, and we have people usually lying down on their back, their knees bent, you're going to put your fingers right inside your hip bones. Take a nice easy breath. Engage the pelvic floor. That's a Kegel, ladies, stopping the flow of urine. When you fire your pelvic floor into a Kegel, you should feel the TA come on. It is a gentle tensioning or drawing in of your abdomen. That's what the TA does. It's deep and it can be hard to feel. And if it's not firing efficiently or very strongly, it can be even harder to feel. And sometimes when it's not working well, what you'll have is compensation of other muscles. And you'll see pelvic tilting, and that's the obliques or rectus coming in. You'll see breath holding and gripping in the abdomen. Or what you'll feel is the obliques pushing your fingers out when you contract them. So that's how we check, and that's how women are supposed to check for themselves. Okay? So here's our cheats. Pelvic tilt, abdomen bulging out, we covered that. So when I teach recruitment of the deep system, everybody who walks in probably has to start at a different place. I might have to start, where is neutral? How do we find nice upright posture? Head over shoulders, shoulders over pelvis, pelvis over ankles. I should have a gentle tilt in my lumbar spine. I cannot be tucked under. This actually inhibits a lot of those deep muscles. And someone will try to get that tucked, gentle curve in their spine by thrusting their ribs forward, and so they'll arch a lot higher up and still be tucked under here. So we might work on correcting that, finding neutral in different positions. Then we work on breathing patterns to get that diaphragm and pelvic floor working together. On inhale, diaphragm drops down. I get about a third of movement happening in my chest. Third of the movement should happen in lateral rib expansion, relaxing this upper part of your abdominals, letting your ribs move, and a third part in the belly. I don't want all chest breath way up here, and I don't want all belly breath down here. So I want balanced breath. Then I look at, is my pelvic floor working? And we might work on getting that sink back together. And then we look at, is the TA now we got this happening, we need the TA to come in a little bit. And once we can find that, and once we can do that, then we change positions and we get into more challenging positions, and then we try to get into function as quickly as we can. Well, there's chest breathing. Yeah, look, I'm running ahead of schedule here. Sometimes we call that balanced breathing umbrella breath. If you imagine an umbrella right in front of your spine, when you breathe in and that umbrella opens, we get a nice expansion all the way around here. And that's often a component that's missing in some of our breathing patterns, because we stay really tight. We stand up straight, hold your belly in, and we get rigid right through here.